Welcome to this episode of the Project Ecto and the Sports Medicine Topics. My name is Anthony Beutler. I direct the Sports Medicine Fellowship that's here in Washington, D.C. and Tri-Service Sports Medicine Fellowship, and grateful to have you all on the line today. We're going to talk this morning about runner's bane of heel pain. So we're going to talk about heel pain and how we can do a better job with that in our clinical practices. A few notes as we get going on. There's all sorts of disclaimers here. This is the slide designed to put you to sleep or numb you into oblivion or whatever here, but I have no disclosures. I work for the Air Force. They don't let me work for anybody else. Some stuff there on CME as well. If you could please, if you're online, please go ahead and mute your microphone or your conference call phone if you're listening by telephone, so we don't get a lot of feedback on the line. That'd be great. If you want to ask a question, the easiest way is actually to type it in the comments box on the DCO online, and then we can see that and respond to that forthwith there. And everybody else can see it as well, so that's the advantage. If you want to just speak up over the phone, that's fine as well. Just make sure you go back to mute after you asked your question so we don't get too much feedback. All right, please join us for other ones as you can as well. Our schedule's up on the web. Quick overview of where we're going and what we're doing this morning. We're going to talk about some cases. We'll talk about overuse trauma, real estate, and differential diagnosis, all of those things together. We'll talk about victims and culprits, evidence-based treatment is where we'll spend a lot of our time today. And then we'll have some questions at the end that are kind of variations on the theme, some things to give us some stuff to think about. And we will have time for questions, so we hope you brought some questions and some clinical issues that you'd like to discuss as well at the end of this presentation. So our goal, as always, is better diagnose and treat for musculoskeletal medicine and our patients that are out there. Let's jump right into our first case here. Let's go right ahead. Our first case then is a 32-year-old male with right heel pain. He recently started running to get fit. It hurts to run, but he can run through that pain. On further question, he has no previous history of pain. He has no previous history of running. It hurts worse with his first step in the morning, and that's what he's got. And you can see him there running away on your treadmill. On exam, he has a normal appearing foot, but he is very tender to palpation over the medial portion of his calcaneal surface of his heel. So the medial calcaneal tubercle is very sore. And he says, yep, that's my pain. You got it right there. So if there's a doctor in the house, if we have a diagnosis, what do we think this diagnosis is? Well, obviously, we think this diagnosis is probably plantar fasciitis, but the real interesting thing is, how did we get there? How do we all recognize this is plantar fasciitis? What are some things that we might look at for that? First thing is no acute trauma. Plantar fasciitis does not usually come on because we jump off of a ladder or because we bang our foot really hard on something. It's an overuse injury. There's not usually an acute distinct trauma. This pain it's worse with the first steps in the morning or when you first get up from a meeting or after sitting for a while. It's classic for plantar fasciitis. It's usually the medial calcaneal tubercle where the tenderness to palpation is at. People describe a dull, quote, toothache daytime pain sometimes. And they also don't have nerve pain or nerve symptoms. They don't complain of numbness in their toes or tingling on their shin or things like that. Another really important consideration in our differential is the fact that plantar fasciitis probably makes up 95+% of all heel pain. So if we were desperate, we could guess. But being good military doctor, we never guess. We always use our great education. So we won't guess. We'll just say, due to all these clues, we think this is plantar fasciitis. All right, if it's plantar fasciitis, what else could it be? Our differential diagnosis in the heel is really like real estate. It's location, location, location. You can see on the screen that there's this person's heel right there, and there's this blue stripe down the middle. That's tarsal tunnel hurts up there right behind the medial malleolus. That's the tarsal tunnel, and so if you see someone with a blue stripe on their ankle, that might be tarsal tunnel. Just kidding, it's not really blue. But the pink rectangle reminds us to talk about stress fracture. Stress fracture of the calcaneus is possible, especially in our military population where we have runners. Stress fractures of the calcaneus usually are tended to a calcaneal squeeze test. And if you squeeze the calcaneus between your thumb and forefinger on that rectangle, and then on corresponding on the lateral side with your fingers on the lateral side, thumb on the medial side, and squeeze that calcaneus across its body, that causes pain. That tends to be where the calcaneal stress fractures come from. Down at the bottom of the black is the plantar fasciitis zone. That's the medial calcaneal tubercle, things down there, and along the plantar aspect of that foot, that's where we usually see plantar fasciitis rearing its head. Towards the back Up high in the mid portion of the Achilles is Achilles tendinopathy, and then down on the green hatch is something called insertional Achilles pain, which is different actually than Achilles tendinopathy. I would be even happier if that green spot were maybe a centimeter farther down. Insertional Achilles pain can range from where that green box is to a little bit even farther inferiorly, almost wrapping around the bottom of the heel. Insertional Achilles pain is different than Achilles tendinopathy, and we'll talk about some implications for that a little bit later on today. Okay, so back to plantar fasciitis. It's important to remember the pathoanatomy. Despite the itis on the end of our plantar fasciitis, it is not an inflammatory condition. That means that if you look at it, there's no neutrophils, right? There's no neutrophils in there. It's not an inflammatory condition. It is micro tears of the plantar fascia. Those micro tears do result in subsequent collagen generation and pain. This hurts, okay, but it is not a truly inflammatory process. Those of you at home, you can take your right shoe off if you want and kind of follow along with us as we talk about this. We're going to talk about victims and culprits today. Very exciting to talk about victims and culprits and put on our best crime scene mode here as we talk about this. So let's go ahead and transport to a crime scene then. If we're going to transport to a crime scene and we're here to investigate, how do we identify the victim at a crime scene? This is really important for musculoskeletal medicine actually, but just think about this for a second. So when you're at a crime scene, how difficult is it for you to identify the victim? Say you're at a murder. Where do you identify the victim? Well, that's pretty easy, right? It's the one line in the pool of blood. He's the victim. That's the easy part of the crime scene. We don't get paid big bucks to identify the victim. We get paid big bucks to identify the culprit, right? And if we're leading to find the culprit, we might need to use advanced detective techniques, right? Like lineups, where we have people line up and we say, well, the person not taking anabolic steroids, please step forward. So that's what we're doing with culprits. Now, this is a very important thing that we look at this because not identifying the proper culprit, not treating the proper culprit, is the most common problem that I see when people send me referrals. Often when I get referrals from my family medicine colleagues, I practice family medicine as well, so I get the referral and I think their diagnosis is correct. When after I've seen the patient, I come to the same diagnosis, but the reason they're coming to see me is that we haven't really found the right culprit. We haven't found what's causing this person to have those symptoms, and since we haven't addressed where the symptom is coming from, we haven't treated the culprit, therefore their victim continues to just languish by getting stabbed repeatedly instead of getting better. All right, so victims and culprits then. In plantar fasciitis, what is the victim? What is being hurt? Well, that obviously is going to be the plantar fascia. That's what's being hurt here, and you can see the plantar fascia pictured there. So if we look at that then, what might some of the culprits be for plantar fasciitis? Well, looking at culprits for plantar fasciitis, one of the most common culprits that we have is a tight heel cord. This occurs in probably 70% of folks with plantar fasciitis. If you look at the diagram here, you can look at this and you'll see that if you bend your ankle back so it makes kind of a 90-degree angle, that's actually not 90 degrees. In orthopedic parlance, that's 0 degrees. 0 degrees of dorsiflexion. You've got to be able to bring your toes back another 15 to 20 degrees back towards your nose, okay, with your knees straight. And if you do that, that means that you have full ankle dorsiflexion. 15 degrees of dorsiflexion is very important. If you can't do that, then that means that you have a tight heel cord, and you might be at risk, increased risk for plantar fasciitis. How does that work? Let's look at the biomechanics of walking and running to see how that goes. Now, this is only true for heel strike runners. If you have more questions about heel strike running versus forefoot running, I encourage you to tune in next month. Our next Project Echo Sports Medicine cast will be about running, and we'll be talking a lot about the different types of runners, heel strike runners, midfoot runners, forefoot runners, and that'll be fun. But for today, we'll focus on heel strike walking and running and how that might interact with plantar fasciitis. If you look here, this is how we walk and run. Those of us who heel strike, we come down on our heel, usually the lateral edge of our heel. We go down in a midfoot stance right here. Our foot comes down flat on the floor. We then roll over. We supinate. We're up in supination, and we roll into pronation, where we roll from the outside of our foot to the inside of our foot. The next thing that happens to us is we resupinate, meaning we go back to the outside of our foot, and then our heel comes up off the ground because our gastrocsoleus gets tight and drags that thing up, and then blah, 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 other things happen. So this is actually fairly complicated if you think about it. Every time you take a step, all these things have to happen. So you go from heel strike to midfoot stance, all those things happen. And while they do that, they're happening on a clock. because you can see the tibia is moving forward on the ankle, on the talus joint there, and sooner or later the gastrocsoleus gets tight and the Achilles gets tight and it drags your heel up and off. And by then, your foot needs to be in the proper position. If you want to try this at home, you can certainly do it. It works better if you're barefoot, so that's why you should take your shoe off. But if you come and if you stand on your heel and you put your heel down on the lateral side of your heel, then go up on your midfoot stance, so put your foot flat on the ground, up in supination, meaning that you're on the outside of your foot. Now go ahead and roll into pronation. So go ahead and roll on the inside of your foot. Okay. Now resupinate your foot and go up on your toes. So go up on your toes, and what you'll feel is that feels actually usually pretty good. So if you're up on the outside of your foot and you go up on your toes, it feels like kind of a bony lock, like you're supporting the weight of your foot on the bones of the foot, which is where you want to bear the weight at. But what happens if you don't have if you don't have 15 degrees of dorsiflexion right here? If you have a tight heel cord, well, then your foot's going to come off the ground actually in pronation, because it's going to come off more in that neutral or 0 degrees of dorsiflexion position right here. So what does that look like? Put your foot back on the ground, get it in supination on the outside of the foot. Now roll into pronation. Roll your foot to the inside of the foot and come up off the ground with your foot in pronation. Go up on your toes, okay? Putting your heel up off the ground. What you'll feel as you do that is you can feel things pull along the bottom of your foot. Instead of a nice bony support to your foot, you actually feel like there's a band that's across the bottom of your foot that's pulling you. That is true, and that band is the plantar fascia, and that's what's being pulled, and that explains why if you're not giving your foot time to go supination to pronation to back to supination again, you can end up with plantar fasciitis due to that pulling across the foot. So a tight heel cord is actually one of the most common culprits that we see in plantar fasciitis. Other common culprits are training error. People run too far, too fast. Muscular weakness. We think of the foot as an inanimate object that just is like a collection of bones, but the muscles in that foot are very, very important. We'll talk more about that in a minute. Overpronation can be a problem. If you have everything normal, but your foot actually pronates too far, sometimes you don't make it back into supination, and that can overload the plantar fascia. Shoes are a problem. If you look at this guy's shoes, this is not a smile over here. This is actually a grimace of pain. If you run in these shoes right here, you too will grimace in pain, just like our fine fellow there, and that'll be a problem for you. So those are our victims and culprits in plantar fasciitis. Now let's talk for just a second about the treatments that we see. Some common treatments that I see and people refer to me are NSAIDs, heel pads, heel cups, steroid injection, ionto or photophoresis. These are all things that my patients usually have tried by the time they come see me in my sports medicine practice. Now these are all fine treatments. Some of them I think I use some of them in my practice too. But what's important to realize about all of these treatments is that all of these treatments are victim-based treatments, meaning that they are addressing the plantar fascia, that which is being injured, rather than really getting to the source of what is causing the injury to happen. None of these treatments address the culprits, the real underlying cause of plantar fascia pain. They're just basically putting a bandage on the plantar fascia. So if we want to look at what the actual culprits are, what would we do to treat a tight heel cord? What could we do to make that better? Well, obviously we could do some heel cord stretching. What can we do for training error? We can talk to our patients about not increasing their mileage any more than 10% per week. What can we do about muscular weakness? We'll teach you some towel drag exercises that we can do to strengthen the intrinsic muscles of the foot and make those better. What can we do in overpronation? There's orthotics or orthoses that we can use for that, arch support things. We can get better shoes. Those are all things that we can do. Let's talk for a second first about stretching. Stretching for the Achilles and the plantar fascia, perhaps even more the plantar fascia, is a must for prolonged relief. This picture over here is actually a handout that's up on DCO Connect. You can download that for you for free. It also has a plantar fascia stretch on there. But stretching is really a must for prolonged relief. This is something that everybody should be doing for plantar fascia pain. Strengthening is the thing that's the other really important must-do thing. Strengthening the calf and the foot intrinsics. These are the strong muscles that should absorb some of the force and the shock of you running and hitting the ground. If you don't absorb that force and shock with foot intrinsic muscles, any force not absorbed by the muscles has to be absorbed by the fascia, and that's going to overload the fascia and cause it to break down and cause plantar fascia pain. This is where I often see that people break down. Everybody thinks, oh, I'm doing my stretches, but strengthening is usually the thing that they're missing that's in the primary care of plantar fascia that people have not done. Ice is also very good. Ice can decrease people's pain. It's especially helpful with that first step in the morning pain. It never causes GI bleed. Ice is great that way, so we're a big fan of ice. Activity modification can be important. Anybody who has plantar fasciitis, I don't need to tell everyone with plantar fasciitis to stop running altogether. Most people with plantar fasciitis can continue to run at least a little bit when they have plantar fascia pain. I tell people stop running all that you are, cut your running back to 50% of what you have been doing. You're going to need the other 50% of time to do your stretching and strengthening exercises that I'm going to give you. But that's what we'll tell people to do. And then, so they'll cut the running back by 50% and do the stretching and strengthening. That is really helpful then. The one person that we do need to worry about just stopping their running altogether is the person with plantar fascia pain whose gait has been changed. If they have a limp, if they can't run with a normal stride because of their plantar fascia pain, then they just need to stop running until we can get that pain controlled. Otherwise, they throw off their whole lower limb mechanics, and their heel's going to hurt for a while, and the knee's going to hurt, and the hip's going to hurt, and the back's going to hurt. That would be very good for me if I were in civilian practice, all those co-pays, great job security, but not so good for me, not so good for the patient, certainly not good for me in the Air Force when I want to take good care of people. I don't get those co-pays. So certainly people who've had their gait changed, those folks need to stop running until we can get that pain under control. Other folks cut back to 50%, do their rehab, and we can usually get them through with just that. Some second line treatment, these orthoses, right? They're first line for people with significant pes planus or pes cavus, especially the pes cavus people. Remember that rigid pes cavus foot, not as common certainly as the pes planus foot, but those pes cavus feet, when you see them, they don't absorb force at all. They don't pronate at all. And so all that force of running, all that impact is on the plantar fascia. And those folks can use some extra cushioning. Orthotics work very well for those folks. Off the shelf, good evidence suggests that off the shelf is actually better for first-time plantar fascia pain than custom orthoses would be. So feel very comfortable sending your person to the store to pick up a pair of Spanko or whatever brand of orthoses you like. The off-the-shelf ones, over-the-counter ones are very good for this. Night splints are also possible. Patients love them, or they help them with their first step in the morning pain, but bed partners don't usually like them. Some of the newer ones are much less bulky than this, are much more likely to be accepted by your bed partner of your patients. Steroid injections, very effective for short-term pain control. Important to use proper injection technique. We'll talk about that a little bit later. Again, it's a victim-based treatment. It just addresses the plantar fascia, but very effective for people who've been doing therapy, doing rehab, but just can't quite get over the hump. They're still having pain and they're a little bit desperate. Steroid injection will control that pain and hopefully get them through that most difficult time. Surgery, I don't remember the last time I referred someone for surgery. We've got so many things that we can do now for plantar fascia pain that are non-operative that I haven't sent someone for surgery in probably, 10 or 11 years. Some other mixed studies things, iontophorophoresis, it might work, it might not. Steroid injection's better for sure, you get the things there. Shockwave therapy, not great for plantar fasciitis, and it hurts like the flying blue devils. It's a very painful therapy. We know ultrasound, therapeutic ultrasound doesn't seem to work very well. Laser therapy doesn't work very well for plantar fasciitis. NSAIDs actually, one randomized controlled trial that suggests that NSAIDs are pretty ineffective for plantar fascia pain. That probably, like you remember, is because there's no neutrophils there, so they often don't work very well for actually curing the pain. They may help them feel better over the short term just a little bit, but they're not going to be very curative. So when your patient comes to you and says, doctor, but what about my heel spurs? If you look there, there's a pretty impressive calcaneal spur. What do you tell them about that? Well, most of the time, my patients come show me that x-ray and say, doctor, that's exactly where I hurt, and every time I take a step, can you see how that heel spur is just going to poke into me and cause me pain? But try to tell your patients, remind them, they're not walking there, right? They're walking back here. This is where their heel hits the ground back here. It's impossible to walk on that spur. That's like on the inside of the arch here of the foot. It's very difficult. It would be hard to put any pressure on that. This heel spur is what we call a plantar fascia traction spur. This is the calcaneus actually trying to reach out and grab that plantar fascia a little bit as it tries to run away and degenerate away. They're very poorly correlated with plantar fascia pain. Lots and lots of people have wicked plantar fascia pain and no heel spurs. Many people have heel spurs and have never had plantar fascia pain. So these really don't correlate well. They're not the cause of the pain. They might be a result of some of the plantar fascia process, but if you see those in a patient with heel pain, you tell them, they say, what about my heel spurs? You should sit in the apple tree and sagely reply, stretch and strengthen. That'll be the best things they can do first line to get that to go away. Doctor, they say, what about my ibuprofen? I really like my little white pills. And you can tell them, just go ahead and think about it there for a second. You can tell them, go ahead and ice, ice, baby. You can sing it to them if you'd rather do that, just like Vanilla Ice did. But ice is probably a better choice than ibuprofen. Certainly less side effect profile, and about the same pain relief for folks. You've heard of the Grammys. Let's talk about the Gramcies. Gramcies are great research that might just be practice changing for you. Some recent articles that are helpful in plantar fascia treatment. This one looks at stretching and strengthening versus shockwave therapy. Not sure how many of you have access to shockwave therapy. It's out there. It's very expensive, pretty time consuming, but it's something that a lot of my patients talk to me about and say, don't I need a referral for shockwave therapy? And the answer to that is no, certainly not first line, probably not second line, somewhere down there, third, fourth line maybe. 102 patients with acute plantar fasciitis. Group 1 got some stretching, Group 2 got some shockwave therapy. The foot function index was better in the stretching group early on, and certainly by 15 months there's no difference. We see that a lot with plantar fasciitis, that it really tends to burn out at about 12 to 15 months anyway, so certainly anything you would do, you wouldn't expect to find a difference at 15 months, since it tends to be self-limited by that time. But certainly early on, the stretching group looked like it did much better than the shockwave group, and perhaps most importantly, the patient satisfaction was 65% in stretching. That goes up a lot if you add strengthening to it. And shockwave therapy only had a 29% patient satisfaction. Patients really don't like shockwave therapy. Not all that effective for their pain, and it actually hurts while you have it done, so that's not a good thing. The Pilot On Award, this award, I mean, how many times do we need to have this, right? It shows, this is lots of people, lots of women. Stretching and orthotics still work very well for plantar fasciitis. If that's not working, get a big hunk trainer to help you do it, then it'll work a lot better. 2013, 2012, a lot of studies about steroid injections. Steroid injections were maybe a little bit on the out. They're definitely on the in now. Think about that. So there's a couple of things combined to it, plus people in all these studies. Steroid injection was much more effective than placebo in recalcitrant cases. Steroid injection is not a first-line treatment. Use it second line for pain relief, and it works very, very well. Ultrasound-guided injections had the same pain relief, same as palpation-guided injections for symptom efficacy. We didn't study the safety of that, but if you know how to do a good palpation-guided plantar fascia injection, that's going to be a very safe injection. You should feel comfortable doing that. You can give your patients some very important pain relief. Steroid injection in the plantar fascia probably lasts for about 4 months. You're not going to cure it. They need to keep doing their exercises, keep doing their stretches, but you can give them a pain-free window in which to do their rehab and maybe start a little bit of running again. That'll give them a little bit of mental health while they wait for their plantar fascia to heal up and feel better and cure long term. All right, then, so looking back at this for the treatments and victims and culprits for plantar fasciitis, some things for us to remember then. We've got all these treatments here that are best suited probably as band-aids for the victim, for the plantar fascia, but the ones that are really going to help us, the culprit-based treatments, we want to make sure that everybody's doing first line for the tight heel cord and the sore plantar fascia, heel cord and plantar fascia stretching. You saw the handout for that. It's up on the DCO Connect website. Muscular weakness. To cure muscular weakness, we want to do those towel drag exercises. That handout is also up on the DCO online website. You can have that and take a look at it. So make sure we're doing those two things, then add second line things as you need to. All right, that was our first case of plantar fasciitis. Let's talk about another case of some common heel pain things. So case number 2 here, this is David. He's a 37-year-old male ex-champion. He's been running to get back into shape for 4 months, and he's talking about right posterior heel pain that he's had for the past 6 weeks. It started as a dull ache at the end of the run, or when he ran a lot of hills. He would get it kind of running up these hills. Progressed with pain with any running, and now it aches for him even at night. He says, boy, even just to rest, just laying in bed, sometimes I have to roll on my side, just putting my heels on the mattress just hurts me to do that, it just aches. On exam, you look at David, and he's got a swollen, tentative palpation, thickened nodule that's about 2.5 centimeters above the calcaneal insertion, right there on the Achilles. I just feel that the Achilles is very thick and sore in that location. He has no insertional tendinous palpation where the Achilles inserts on the calcaneus. he has very tight ankle dorsiflexion. He definitely does not have that 15 to 20 degrees of dorsiflexion we talked about as being optimal for runners. So, looking back at our real estate slide, where would you think that David might be sore? Well, it looks like that David is probably talking about being sore right up there in the Achilles tendinopathy range there in the orange is where he's got his tenderness and his swelling that's going on there. Probably not down here insertionally, probably up at the mid portion Achilles tendinopathy. Okay, so what do we do with that? Well, the important thing with Achilles tendinopathy is to separate out acute from chronic symptoms. So what do we do with acute? Acute, we say, is less than 6 weeks of pain. So David is right at the 6 weeks, so he's certainly on the more chronic side. But if he had come in 3 weeks before, what would we do differently for him? Well, we might be a little slower to recommend our chronic symptom treatment. We'll talk about what that is in a second, but just remember that when you have somebody with acute Achilles pain, be very certain, be very sure that you're not dealing with a rupture of the Achilles tendon. Remember, those can happen often pretty atraumatically and pretty unimpressively, so you've got to make sure that that's not a rupture. One of the best ways to do it is just watch it for a bit. If they don't have a complete rupture, right, their Thompson squeeze test looks okay, you're not feeling a big defect back there, they don't have a big swollen Achilles that looks like it's detached. If you're worried about a small partial Achilles rupture, you can do some of this other stuff and wait for they've had their symptoms for 6 weeks, and then it'll be better. Chronic is more than 6 weeks, and we treat them differently. We always think about, for acute injuries, doing RICE treatment. What is RICE? It's our first-line treatment, relative rest, ice, compression, elevation. Does it work? We don't know. It has a really horrible level of evidence. You know, do NSAIDs work for this? Is there inflammation involved in the acute phase of tendon injury? Is inflammation good or bad for healing? We go back and forth on that. Stretching, could we do that? Could we improve flexibility? Certainly David has some flexibility deficits. We could certainly work on that for his first 6 weeks. You're not going to hurt anybody with a nice passive stretching program like you see here. Make sure they put this black rectangle over their eyes so we don't know who they are while they're doing stretches. That helps the stretch as well. Level of evidence for this, we don't know. Stretching might work for acute Achilles tendinopathy, it might not. So acute really has horrible level of evidence C or maybe even D. We don't know if it really works or not. Not true for chronic. For more than 6 weeks, when you get more than 6 weeks of Achilles pain, what we really want people to be doing is an eccentric exercise program. And we'll talk about that in just a second. Remember, eccentric, concentric. Muscles only do one thing. They only contract. But they can contract concentrically or they can contract eccentrically. Okay, let's look at that for a second. Here we can see that if this person is lifting this very heavy barbell up towards them, up towards their shoulder, their biceps is going to be contracting concentrically. It'll be firing, and it will be shortening. That's a concentric contraction. An eccentric contraction will be when they go to put that very heavy barbell back down on the table. The biceps has to fire as kind of a brake, right? It has to fire to kind of slow the barbell down as it goes down, but it's firing while it's lengthening. That's an eccentric contraction. Eccentric contractions are actually associated with a lot more force, a lot more muscle activation. They're one of the most difficult things that your muscle does. It kind of tears it up. You can imagine the muscle being used as a brake, just like your brake pads on your car. To use anything as a brake tears it up and wears it down. So eccentric contractions are very important to us athletically and physiologically, but we need to recognize that they're associated with very high forces as well, and they can be quite destructive and inflammation promoting, if you will, on the tendon and in the muscle. All right, so let's practice then. As this person strides forward, okay, it looks like that she's going to land on her heel here. So what muscles are eccentrically contracting as she lands on the ground here and begins to prepare for her next stride? So in this leg that's just about to hit the ground here, what muscle is just about to eccentrically contract? Well, if she's a heel striker, then one of the first muscles to eccentrically contract will be the tibialis anterior, right? Because she's going to land on her heel, and that tibialis anterior will lower her foot down on the ground in a controlled fashion. That will be an eccentric contraction of that tibialis anterior, lowering the foot down to the ground. The other muscle that's very eccentrically active here is going to be the quadriceps muscle, right? She's going to land, and if her quads don't fire at all, she's going to hit the ground and she's going to collapse. So the quad has to fire to kind of catch her, break her, and then push her back up off the ground. So the quad's going to do, just like the tibialis anterior will do, it will do a eccentric followed by a concentric contraction, but eccentric first. All right, so those are some eccentric contractions. Let's look again at eccentric contraction. Which muscle is essentially contracting here? Well, not a muscle. This is a PCL that's eccentric contracting. It doesn't contract, so it just ruptures, but that's eccentric contraction. All right, good. Let's try this one here. What's eccentric contraction here? Well, this, people always get the wrong idea here. People just think badly about people. But this person in the red, the player in the red here, is a very caring sports person. He's seen this person in the green in a vulnerable position, and he has extended his leg, and he is slowly lowering the green person back down to the ground in a position of safety. So this is an eccentric contraction of the hip flexor as he puts this green person back down on the ground. So eccentric contraction, enough examples. Let's talk about it for a second. Let's look at the evidence for eccentric exercise in tendinopathy. If you look at eccentric exercise, and you do a simple PubMed search on this, this is an old slide, but you find out that the first time eccentric exercise is mentioned is way back in 1986, 1989 with Stanish, Kerwin, and Rubinovich. Probably because their names were not very catchy, people kind of forgot all about them way back in the day. The next citation that you see is in 1998. It's from a man named Håkan Alfredsson, okay? And Håkan was the one who first published this resurgence, the renaissance, if you will, of eccentric exercise in 1998. If you look then at the rest of the graph, the things colored in dark blue are the contributions that Håkan Alfredsson had to the eccentric exercise literature. If you look, he's one of the only people talking about it for a while, and then as it starts to take off, he's still very heavily involved. So Håkan Alfredsson is probably the father, if you will, or at least the restorer, if you will, of our understanding of eccentric exercise in tendinopathy. How did this come about? It's an interesting story, so let's tell you what the story is for Håkan Alfredsson. Håkan is an MD, PhD orthopedic surgeon in Umeå, Sweden, okay? And he is up in Sweden where they have, 3 whole weeks of summer and the rest of the time is winter. And all I know about Sweden is this thing about, that's where it is, right? And then team handball is big in Sweden, and this is what team handball looks like, and I would just show you that these are all women, and they're scary looking women to me. So that's all I know about Norway. This isn't that. So Håkan is up there and he's playing handball. He's working out. He's really looking forward to summer because it's his time to golf and do those things. He develops Achilles tendinopathy pain. And as he develops this pain, he's just debilitated by this. And he goes to his other orthopedic colleagues and says, you got to do surgery on me and fix me. I'm going to be miserable for the upcoming summer. And they say, forget it. We're not going to do surgery on you because if we do surgery on you, then you're going to be out of commission and we're going to have to do all of your work during the summer. So we don't want to do that. You're just going to have to tough it out, wait for it to be winter again, and then we'll exercise, then we'll operate on you and get your Achilles taken care of because we don't want to do your work over the summer. We want to golf and do those things as well. So Håkan says, well, this is a bummer. I know what I'm going to do. He has this great idea. He says, I've been taught that the one thing we should never do in tendinopathies, we should never exercise it eccentrically because we might rupture the Achilles tendon. So I'm going to go into the gym and I'm going to do eccentric exercise, these negative calf raises, right? And I'm going to rupture my Achilles tendon because that is a surgical emergency, and if I have a ruptured Achilles tendon, they'll have to fix me, and then I'll be better for summer and I can do my things that I want to do. That sounds crazy, but that's what he did. So he went into the gym and he started to do his exercises, and he did his eccentrics, and his Achilles started to ache and hurt and get more symptomatic. He said, yes, it's going to work, it's going to rupture. And then his pain kind of went away. I said, well, maybe that wasn't enough weight. So he threw some weights in a backpack. He started doing eccentrics again with his weighted backpack, and it started to hurt again. He said, yes, it's going to rupture, it's going to get there. And then his pain went away. And in fact, at this time, his pain was all gone. His pain was completely resolved. And he said, now, wait just a second. What happened there? And so that was an unexpected outcome to what happened. As I tried to make myself worse, I actually made myself better. At this point, his PhD scientist brain takes over, right? And he says, let's try this in a larger population and see what happens. So Håkan goes back to his surgical practice. He finds 30 people who are on the books awaiting Achilles surgery for long-term tendinopathy. He takes 15 of them and puts them back in conservative therapy, stretching, ice, NSAIDs, all those things that they're supposed to do, and follows them to see how they're doing. 15 of these folks he takes and puts in the eccentric exercise program, where he has them do basically these negative calf raises, and develops his own protocol on how he's going to do that. And he looks at them for 12 weeks. After 12 weeks, 15 of the 15 in the exercise group are back to full activity and say, we do not want anything to do with you and your scalpel, leave us alone. 0 of the 15 on the conservative therapy folks are back to full activity, and all of those folks still want surgery. So Hakan puts these people, the 0 to 15, back in the eccentric exercise program, and at the end of 12 more weeks, 14 of 15 of those folks are completely back and want nothing to do with surgery. He says, wow, that's really unexpected. But that is really the birth of the renaissance, if you will, of our understanding of eccentric exercise and tendinopathy, and certainly eccentric exercise and Achilles tendinopathy. This is highly effective. 80 to 90% of folks who do this program for 12 weeks have a satisfied return to their activities. They show significant benefit. This may not be enough for competitive athletes, professional athletes. We may have to do additional things for them. But for everyday folks, this gets them back. They may still have a little bit of Achilles pain, but it gets them back doing what they want, and they don't talk to you about surgery anymore. Most of them are exceptionally happy. About 80 to 90% or say they're completely cured by this and ready to go back to their regular lives. The effect of the eccentric exercise may wane over time, but it still exists after 5 years. And if you notice that it starts to go away, you can just start hopping up and doing exercises again, and the effect comes back. It seems to work well on the rebound as well. Very good surgery, level of evidence A, very good therapy, level of evidence A that this works very well for Achilles tendinopathy. So again, for acute, we're not really sure what to do. It has very poor evidence, but for chronic, we want to make sure they do an eccentric exercise program. That's going to be great level of evidence for them. We could also use a nitroglycerin patch. This is interesting, right? Is my tendon having a heart attack? No, it's not, but nitric oxide does cause fibroblast proliferation, collagen synthesis, macrophage activity, increased blood flow to the site, all these things that we think might be useful and beneficial for people with tendinopathy. So what we do with this, it is totally the world's simplest therapy, right? You can see this patch on this guy right here. This isn't where we want to put it for Achilles tendinopathy for sure, but we take the smallest nitro patch we can find. I can usually find in the military formulary the 0.1s, so I'll take the 0.1 milligram patch, cut that into quarters, okay, and have the person put that right over where they're getting pain. What can they expect? They can expect the same things that everybody who put nitro patch on. They can expect a little bit of a headache for the first couple, 3 days. You treat that with Tylenol, it goes away, they get accustomed to it, it doesn't cause any long-term problems. If they don't have enough blood pressure, they can get some orthostasis with that, so you have to be careful. Most people with tendinopathy are 40 to 50-year-old men. They have plenty of blood pressure for a 0.1 nitro patch, so you don't have to worry about it. But this is not a great therapy for your 20-year-old females whose blood pressures are 85 over palp. But these are some of the things that you'd want to look at. You have them put that nitro patch on there, and then you put the nitro patch on, and they don't have to take it off every 12 hours. They can leave it on for 24, or they can take it off before they go to bed. But they want to change that every 24 hours. And it does seem to work quite well. Looks like we had a question come through. What's the question? Oh, good. So, question on the headache for the side effect of nitro patch. Sure, that's a good question. I tried to just answer that. There can be. It's mild, goes away after a couple of days. You can use Tylenol if it's bothering them for the first couple, 3 days. But I've never had anybody complain to me after 3 days. It is the world's simplest therapy to institute, and very cheap, and it does seem to work pretty well. Here's the numbers for it. So here are folks that, again, this is second-line treatment. I don't tend to use it first line. I'll put them in the rehab program, but if they're not better after 12 weeks and they come back and they say, oh, I've still got some symptoms, this is something that we can add on, right? So if you look at somebody who's doing nitroglycerin plus their rehab, okay, those people, 78% of those folks had an excellent response to their therapy. 22% of them said, I didn't really change much, right? And none of them said it made them worse. This study did have people who had a placebo patch. It looked just the same. It had, flour goo in there, so it looked like it had nitroglycerin in the patch as well, but it was just a placebo patch plus the continued rehab program. 49% of those people got better. So again, discontinued rehab will make half the people better. 44% of the people said they weren't any better, and 7% said, nah, actually I think I'm a little bit worse. So does nitroglycerin make people better? It is associated with a higher chance of an excellent outcome, so that's helpful there. It certainly doesn't make things worse, and it's something you can add on. The effects persist, we know, in clinical follow-up for even 3 years out. If you give them about 6 to 12 weeks of a nitroglycerin patch therapy, even 3 years after discontinuing the nitro patch, they'll still say, yeah, my tendon feels better. So the question I often get asked is, can I use this for other tendons as well? The answer is absolutely. Any tendon that you think has tendinopathy, Different than a tendinosynovitis, right? The Quer veins in the thumb, that's a tendinosynovitis, that's inflammatory. That won't work very well with nitroglycerin, but a rotator cuff tendon, that's pretty deep. It'd be difficult for the nitro to get there. You could try it. Lateral elbow, this works pretty well. Patellar tendon, this works pretty well. Any tendon that's pretty accessible that you think is having tendinopathy symptoms, you can use a quart of a nitro patch and about the same effect, about the same side effect profile. All right, so let's talk about then David. He has this non-insertional, this mid-portion Achilles pain. What are you going to do for David first line? Well, obviously, he's had symptoms for long enough. He needs to get on this eccentric exercise treatment program. There's a handout up again on the DCO Connect about how to show your patients how to do that. A little bit of background on what eccentric exercise is, but David's got to get religion. He's got to get working on these eccentric exercise stuff. If he's not any better after 12 weeks, what else could we add? So looking at David, we would just guess that he probably has enough blood pressure to use maybe maybe nitro patch. He's probably not an elite athlete. If he were an elite athlete, maybe we'd do shockwave, maybe do prolotherapy. Certainly supervised eccentrics would be a second line thing. We'll talk about this over and over. If your patient fails their home exercise program, the next thing is to send them to PT and have them supervise their exercise program to make sure they're doing it properly, they're actually doing it. Ex-champions like David, I wouldn't use prolotherapy so much. I would tend to do nitro patch plus more eccentrics, plus minus supervision. If he's got it, if we can do it, we'll do that for sure on him. Third line treatments are the fancy stuff that we do in sports medicine. Send them to us if they're no better after your second line treatments. Now let's talk for just a second, I told you we would, about the fact that not all Achilles pain is mid-substance. David's pain was here in the mid-substance of the tendon and Achilles tendinopathy there. What's different then if we have insertional Achilles pain, if we have pain that's down here at the calcaneal insertion? What do we do differently for that? Well, let's say that David now had pain that was down at the insertion. What would we change? His first line treatment is still eccentric exercises, okay? But instead of dropping down off of a step, you probably saw in the pictures that we're going up on our toes on the edge of the step and then dropping all the way down. So our heel actually goes below neutral, drops down below the edge of the step. And that full range of motion, that full 15 to 20 degrees of dorsiflexion is important for mid-portion Achilles tendinopathy. However, it's bad. It's been shown to be not good at all for insertional Achilles pain. Because the tendon makes a tight turn, the forces are different at the insertion. So you should be doing those eccentric drop-down exercises only to 0 degrees dorsiflexion in a neutral position. So they do the same exercise, but they do it on the floor instead of on a step. So they can't drop down too far. So I'm going to change his exercises to be done on the floor. For second line treatment, there's a couple of things we could do. Shockwave therapy has been shown to work better for insertional Achilles pain than it does for mid-portion pain, so we might try that. But again, that's very painful, very expensive, hard to find. The other thing we could do is we could immobilize him. We could put him in a walking boot and then put him in a walking boot until he's no longer sore, no longer tendon palpation on the heel. And then we could start at the eccentrics and do pretty well. We could add a nitro patch if we wanted to while he was immobilized and then do eccentrics. There's all sorts of things that we could do to try to be helpful to David over this time course. Third line treatments are things, again, that we would do in the sports medicine clinic. Send them our way if you get stuck. But that's some of the things we're looking at. Nitroglycerin patch, I'm not sure that's third line. I might add that to second line when we're thinking about immobilization. Surgery certainly is out there. Insertional Achilles tendon pain is just more difficult to treat than mid-portion Achilles pain. So it's just a trickier entity. But remember these tricks, and that will get you on the start on the right path. All right, so with that being said, those are kind of our core cases. We're going to take just 2 minutes to go through some other quick cases that give some variations on the theme, and then we'll open up for questions in our last 10 minutes and see what questions you all have. So our variation here is our company commander, lots of 4s here. Case number 4 is our 44-year-old company commander. Bilateral heel pain was running for 6 months. Hurts worse with the first step in the morning or standing after a long meeting. No numbness, tingling, no constitutional symptoms. On exam, they have tendon palpation of the plantar fascia right there on the medial calcaneal tubercle. Mild pes planus. And you think to yourself, hey, we got it, right? Plantar fasciitis. But they say, hey, I saw your colleague in clinic 4 weeks ago. He gave me these stretching and strengthening exercises. I've been doing them religiously, and you know what? I still hurt. I'm not getting better as fast as I'd like to get better, and I have to run. I have to be able to run, and I'm not able to run, and you must fix me. You know, I've got to be able to run to survive in life here, right? I'm frustrated because I have to run. what do you do now? What are you going to tell this person? What things could you do? Well, let's talk about that for a second. Whenever we talk about secondary screening of the patient, we want to talk about the first questions, right? The first question out of your mouth needs to be, did you do your rehab? So, I mean, what were you given to do? And then show me the money, right? Show me what rehab you do. Because people say, well, I do this rehab with a pillow. And you say, and you don't know what it is, right? Are they standing on the pillow and actually doing the rehab? Or are they doing this kind of rehab over here with their pillow? Who knows what they're doing with that pillow, right? If they have been doing a rehab program for a couple weeks, for 4 weeks for this person, every day like they're supposed to, they won't say, oh, I have a sheet at home and I do some of the exercises. No, they can bust it out in the clinic. If you've been doing it every day for 4 weeks, you know what you're supposed to do. So make sure the people are doing their rehab, and if they haven't done the rehab, then that's a different story for them, what they're supposed to do. If they have done their rehab and they're not getting better, let's go back to our second line treatments and let's pick some that we could do. Could we give this person orthotics? Absolutely we could. That might be something I'd start with. Could we give them night splints? We could. I'm not sure I'd start there with this person, but you certainly could. I might use a towel stretch or something like that instead. Steroid injection, I would certainly consider that for this person. Sounds like they're an avid runner. If they really want to get back, and a steroid injection might give them enough pain relief that they can start to run a little bit while they keep doing their rehab and some things that they could do. So remember, if they're having secondary pain, if they've tried initial things, pull up your secondary slide, see what things you can find for them to do there. But don't forget, they've got to be doing their first line stuff first. Make sure they've been doing their rehab and they can demonstrate it for you and that they've been doing it properly. If they can't do their rehab, or if they can't do it properly, haven't done it, consider supervised rehab programs. Send them to physical therapy and have them work with them, see if that makes it better, and it will. Case number 5 is our 25-year-old infantryman, bilateral ankle pain after running 2 miles. Okay, symptoms have been there for the past 6 weeks. No trauma. He gets numb and tingly when he runs down the bilateral soles of his feet. He gets numbness and tingling down that way. On exam, he's normal. He doesn't have any tenderness anywhere. His exam is completely normal. And you say to yourself, is this plantar fasciitis? The answer is no, this is not. Is this Achilles tendinopathy? No, it's not, right? He should be tendinous over the Achilles if it's plantar fasciitis or Achilles tendinopathy. This could be a lot of different things, but it's certainly not one of these things. So don't treat this as plantar fasciitis. Don't treat this as Achilles tendinopathy. This is probably a good thing to send to your sports medicine doctor and see what they have. Or click on our Ask the Expert button on our website and we'll help you sort through it. Case number 6, 19-year-old E3 female. Right midfoot pain running for the past 6 weeks. Hurts kind of right under the laces of her shoes. She has no acute trauma, but it's progressively getting worse. It's gotten to the point where it was just a little ache after long runs when it started off, and now it hurts even sometimes at night when she's sleeping. It just hurts all through the day, that dull ache under her laces. It's really bothered her, getting to the point where she can't even run anymore because it hurts so bad. On exam, she has no tenderness palpation of the plantar fasciitis, no tenderness palpation of the malleoli, no tenderness palpation of the Achilles tendon. So is this plantar fasciitis? Is this Achilles tendinopathy? No, it's not. This probably is a stress fracture, probably a bad stress fracture. Again, this is something that needs to go see. This kind of violates our rules for the plantar fascia and the Achilles. There's got to be tendon palpation somewhere we can mash it, right? And if it's not, then that's got to be probably go see our sports medicine doctor or click the Ask the Expert button so we can help sort you through this one, because this is going to be a complicated case that we don't want to get wrong. Yeah, tendon palpation of the navicular, that's probably a navicular stress fracture. That's going to be bad. All right, so we've tried to go through some things. We've done some core cases. We've talked about overuse injury. We've talked about real estate, and that our differential diagnosis really depends on what section of the real estate we're getting to. We've talked about victims and culprits, what's being hurt, what's underlying the hurting, how we treat those, how we get things better. Evidence-based treatments, what's been shown to work, what's been shown to not to work. Variations on the theme. Remember, not everything in the foot is plantar fasciitis or Achilles pain. So when you see things that are outside that spectrum, get some help, because those are complicated things. Those can be difficult to do. Happy to take your questions now at this time. So if you've got questions, you can ask them over the microphone if you'd like, or you can type them out and I'll get to them online. Okay, we've got a question here. It says, I'm worried about doing steroid injections in the plantar fascia because my orthopedic surgeon told me that they cause plantar fascia rupture. Is that true? Hey, that's a great question. I would say that there is very, very limited evidence that steroid injections cause plantar fascia rupture. Now it's true that sometimes they're associated. People who have plantar fascia ruptures have long-standing plantar fascia pain, and so often they get steroid injections to treat that. So they show up with an orthopedic surgeon and they blame the steroid injection for causing that plantar fascia rupture. But there's really very, very little evidence for that. I think that more commonly the plantar fascia ruptures before or was going to rupture anyway, and they get a steroid injection along the way. If they do happen to get a plantar fascia rupture, it's not the worst thing in the world. That actually is one of the treatments that they use when they go in to do surgery, is that they just kind of release the plantar fascia. So it's not necessarily a terrible thing when that does happen. But I would say don't be afraid. I'd be more afraid of fat pad atrophy over the calcaneus. So make sure you're getting your steroid injection. If you're not doing an ultrasound guided, make sure your palpation guided technique is getting the steroid deep enough so you're not in that calcaneal fat pad. I'd be much more concerned with that than causing a plantar fascia rupture for sure. Another question coming in here, Captain Lemley, stress fractures. That's a really good question, David, and I hope you'll do a study on that. So his question is, with stress fractures commonly seen in young soldiers with poor bone quality, what is the goal vitamin D level? Is there any benefit getting the vitamin D level above 30? That's a great question. I'll tell you that I will always check a vitamin D level in people that come to see me with a stress fracture. If it's below 30, I will treat them with vitamin D, but I don't know if what I'm doing makes a difference or not with them. I think it does. It makes sense to me that it does, but we don't understand everything we know about vitamin D. It may be one of these things that, like folate and other vitamins that we give people, that we turn out in 5 years that we're causing more harm than we are causing good. I'm not sure, but would be a great study for somebody to do, to look at that prospectively and see if that actually makes a difference for folks. But in my practice, anyway, I will check that. I will supplement it if it's below 30. I'll do that to try to help people, but I don't know that there's no evidence that says that I'm really absolutely making it better. Let's see, another couple questions here. Let's look here. What if a patient with plantar fascia pain just isn't getting better? He's been doing PT religiously for 9 months. He's tried orthotics, night splints, steroid injection. The pain came back to 3 to 4 weeks. Came right back to where it was. What else can we do? That's a great question. And one thing that I'd tell you with that, and with just kind of with our variations on the theme, I'm going to skip out of my PowerPoint here and go someplace else on my computer to show you something. I hope this is a resource that you're all familiar with. Write this one down, if not, hprc-online.org, okay? And then when you get to that, that's what this page looks like here. We're at the HPRC Online. This is us. This is the CHAMP Consortium, the Human Performance Resource Center here at the Universal Research University. Click on Physical Fitness. At the top of what we need, you can see here there's a couple of places you can find it, but if you scroll down, we're part of the Rx3 Consortium, the Rx3 project. If you look at this, there's some resources for the service member, for the provider, frequently asked questions. Okay, let's go to for the provider for just a second. When I click on for the provider, you can see that there's all these resources that you can use to try to get better on these things. Most of them are coming soon. We're building them. We're trying to build them fast. I'm trying to help out with heel pain thing here, so hopefully that'll be up there soon. Knee pain is up and ready to go. But the most helpful button on this page is this one right here, which really gets to this question that was asked. What do I do for someone who's 9 months and not getting better before they even get to 9 months? When you've exhausted your first line therapy, when you've exhausted your second line therapy, or if you just don't know what you're supposed to do, come click on this button, the Ask the Expert button. If you click on that, you get a little form. You can tell us a little bit about what struggles you're having. We can get back to you. We can get back to you and say, consider this. You might want to try this with some medical advice. Or we can say, you know what, this person needs to go see a sports specialist. Where are you? Let us help you get hooked up with the closest sports medicine doctor that's close to you. We have really good feelers about who's out there in the network. We can usually find somebody who's close to you who can answer that question to make them better. Certainly somebody who's had the workup that you've described after 9 months, that person should be getting better, and it'd be great to get them the help they need. Do you ever consider immobilization or non-weight bearing as a possible treatment for plantar fasciitis, like a walking boot or a cast? For plantar fasciitis, not so much. If I want to offload the plantar fascia, the way I'll offload that is often with a little heel cup or a heel rise thing. I don't tend to use a walking boot for that. You can certainly use a walking boot or a big orthotic with a heel rise in it if the patient has a plantar fascia rupture, but that's more of a podiatry foot and ankle ortho problem, so I don't think I'd routinely do that. So no, probably not for plantar fasciitis. I wouldn't routinely use immobilization. Not true though for Achilles tendinopathy, especially the insertional Achilles tendinopathy. Insertional Achilles tendinopathy, I think, is probably actually best treated if you can immobilize those people until they're no longer tendon palpation. Sometimes it takes 2 weeks, sometimes it takes 4 weeks, sometimes it takes 5 weeks, but usually between 4 and 6 weeks, they'll get better to the point where you can now mash on that insertion of the Achilles tendon on their calcaneus and it doesn't hurt anymore. And at that point, you can add your eccentric exercises just going down to floor level, right, on the insertional Achilles tendinopathy. And they tend to do very, very well. So I will use immobilization for insertional Achilles pain. I don't tend to use it for plantar fascia pain, just haven't found it to be super helpful. There are other things that I can use, like my steroid injection to control the pain. I can use Voltaren gel to control the pain. There's other things I can use to control the pain. I don't usually have to go to immobilization for plantar fasciitis. All right. With that being said, we're coming up pretty much close on the hour. If there are any other questions, you can fire them off to us now. Otherwise, I will just remind you again, the hprc-online.org, hprc-online.org website. Click on physical fitness, get to the Ask the Expert button. Send us your questions, we'll answer them for you. There's also going to be lots more resources there on the For the Provider page so that you can get there and click on the things that you need. We hope to have the patient page up and going well too. And just remember that we have upcoming seminars. We do this every month. Our next one's going to be on running and running shoes. We'll talk about heel running, we'll talk about midfoot running, and we're going to have some new people on that. That'll be very exciting. So please continue to send us your feedback. If there are things that you'd like to hear about that we're not talking about, let us know that too. And we look forward to seeing you next time on the next Project Echo website. And talk to you all soon.